So hello to everyone. My name is Raul Segundo. I'm a physiotherapist, osteopath, and an EOM professor. Here I've got the pleasure to invite one of my best osteopathic friends, my friend Tom Herbecko. He's also a physiotherapist, osteopath, and an EOM professor. Hello, Tom. We finally started this, Tom, with all those amazing problems we got with the connection. So
great.
I know we've got some, some technical problems. We're going to finish them talking about what we love. What we love is about the diaphragm clinical connections. Okay, Tom?
Excellent. I'm really happy to be here, Raul, to be speaking with you about this. Diaphragm is an incredible piece of anatomy.
Okay, so this talk is maybe to show everyone the important aspects that the diaphragm has, and even though that maybe make our colleagues try and use the diaphragm in the clinical, when they treat the patients. What do you think about it, Tom?
Oh yeah, definitely, Raul. I think that while diaphragm could be like one of those important parts of the body that once we treat it, we solve a lot of problems. So I think this could be a really interesting topic for all. And I think it could help you understand more the diaphragm and how the body works.
Okay, so we're going to start talking about what we think is so important for the students, for our colleagues, for the physiotherapists, try and match the anatomy with the clinical aspects that the diaphragm, and something very important for us that the phrenic nerve is, and we're going to, both of us are going to try and make our colleagues and our students and our future EOM students remember what we got here, because when you talk about the diaphragm, you think it's only breathing aspect, and when you talk about the diaphragm, you have to have firstly the structural functional anatomy connections. Remember, Tom, that this is something that you know better than I do. You've got the right cruise and the left cruise. They go upwards here, and the intertrees here, they turn, they twist here, and they do a first hiatus and the first opening. That here comes the thoracic duct and the aorta here. This is a very important key part. Okay.
Yes, exactly. So also the cruises are important for esophageal function. So in the case of acid reflux, we have the top part that we're going to speak about later on.
Yeah.
So this is really interesting because we can actually control through different treatments this acid reflux.
Yeah. Here the right cruise and the left cruise, they continue upwards, looking forward, to get to the central tendinous of the diaphragm, and they do another opening here. They make another opening here for what you just said, for the esophagus, and for one of the most important nerves. Right now there's a lot of scientific works here of the vagus nerve, and I think it's very important. Later on we're going to see image about some new connections that we've just they've just written about the hiatus here in the esophagus. Here's one of the hiatus here, and really upwards you got one for the vena cava inferior. Right now, just for this anatomy, this simple anatomy we just talked about, we've got something really important here that is, you know, the amazing vascular, you know, importance that the diaphragm has here.
Definitely, I think that's one of the underlooked parts of the functions of the diaphragm, and it's actually one of the most important. There are some scientists that speculate that actually the origin of the diaphragm was just for blood flow. So, and then later on, the other parts started happening. So we can really control the health of patients, especially in the lower limbs. And the whole digestive and digestive parts and kidneys, everything is important of how the diaphragm moves. And if there's little movements in the diaphragm because of stress, because of our hardcore life, then that blood flow will be impeded. And so Raul will talk about that later, and that's an amazing and important factor. So it's not just the heart that pumps the blood, it's also the diaphragm.
Yeah, that's great. Okay, so the first thing we gotta remember, you know, here is the psoas major connection and the quadratus lumborum connections, you know. You know, the diaphragm, that is something that we talk when we meet. The diaphragm, you know, it's going to adapt what the lower limb dysfunctions transmit, you know. When you've got some ankle problems, you've got some, you know, some knee problems, some knee injuries, you know, that's something that's in ascending dysfunction that you can find, and you got some adaptation here on the diaphragm. Even though this is something really good, there is something that we talked, you know, sometimes about the, you know, the right and the left ureter, you know, they're really close to the quadratus lumborum, and that is something that some patients tell you when they got some, you know, some problems, some stone problems, you know, in the kidney, you know, they tell you that they got some low back pain and, you know, and some pain coming through this pelvic region. So that is something that you can, that I think you can, you know, you've got to have it on your mind always when you're treating a patient with that symptoms.
Exactly. The ureter, and also, you know, as we see the kidneys, we also have the large intestines there, which is really interesting. We might have some person with like diverticulitis, and then next thing you know, they have quadratus lumborum pain and so on. But it's interesting because the psoas and the quadratus lumborum, they kind of attach to this ligament in the diaphragm. So the movement of the diaphragm will also influence the psoas action and quadratus lumborum action, which can also create more visceral problems and vice versa. So there's always this crosstalk between these muscles and these visceral organs, where the diaphragm is the main player.
Yeah, that's it. You know, that is something I forgot to tell you. You know, here you've got the arcuate, the psoas major ligament here that connects with the right and the left cruce, you know, and even though the lateral, you know, here we've got a lateral ligament that connects with the quadratus lumborum with the diaphragm, you know, that's the connection. Okay, that's great. You know, even though we've got here some connections that the psoas major has with you know, with some nerve, some lumbar nerves here, with the genitofemoral ligament nerve here. We've got some connections with, you know, with all these sympathetic lumbar trunks, you know, and that's why you know here that here's the connections that we talked later, you know, and here we've got all these connections that they are very important. You know, this is something that you talked here, Tom. Here you've got something that is missing here. You've got the thoracic duct coming here, really close with the aorta.
Exactly. So thoracic duct, the Peckett cistern, or the cistern of Kylie, which kind of collects all of the lymphatic system from the small intestine and from the digestive system, and also from the lower legs, and it brings it through the diaphragm all the way to the where it goes to the left subclavian vein, and where it gets basically breathed out and processed, and some of it goes back into the circulation system. So this is very important for example, inflammation, especially if you have somebody, let's say, has a knee problem, like a meniscus tear, where they'll have a lot of inflammation in the right knee. So if there's not a good diaphragmatic function, we are going to have a lot more inflammation and a lot more of this lack of movement of this lymph material. So lymph material is basically only moves, it's not like the blood circulation, it only moves through the change of the pressure of the diaphragm. So when we breathe, we actually, we can say we become less inflamed, less painful, and also through movements, just skeletal movements. So we need both of these things to move the lymphatic system towards the thoracic and to be exposed in the subclavian vein. So moving the diaphragm, we're going to have a lot of effect on lower inflammation of anything below the diaphragm, which is amazing. And also of the lungs, because, you know, the diaphragm is going to pump out those lymphatic material through when it's moving correctly.
Yeah, that's it. That's it.
Mm-hmm.
Here we've got some important connections, you know. We talked about it afterwards, you know, and before. And here we got some strong connections with all the, you know, the heart, the pericardium, you know, here. And this is very important, because when you breathe in, when you breathe out, you're going to move the heart, you know, even though that's the way, that's how the heart gets in some new blood, you know, and gets out through the venous system, you know, gets you know, his blood, and you know, you get it's moving around the blood circulation of the heart, you know. And that is very important, because this is something that when we read about rehabilitation of the heart, you know, some injuries and, you know, some stroke and some stuff like that, you know, they you know, recently I've read that they've introduced some diaphragm rehabilitation. You know, they've seen that the diaphragm is blocked and it doesn't move correctly. And right now they've seen that it lowers the time that the patient is in the hospital, and it lowers the time, you know. This is very important for the hospital rehabilitation, you know. And I've seen it right now in recent articles, and they didn't get it in. And, you know, it's so close, the relationship with the heart, the anatomy is so important that, you know, I thought it was something important that our students and our physiotherapists could know about this. You know, even though you've got here some very important connections with the phrenic nerve, the right one, the left one, Tom, and, you know, all the pericardium is really full with some branches here that we could know. This is why we can know that the heart, you know, brings the referred pain to the left arm, to the temporomandibular joint in the left side, and to the neck.
Mm-hmm. Definitely. When we have, we're going to look at referred pain later, and it's amazing how much the diaphragm will influence visceral visceral pathologies, visceral tensions, and also its referred pain. So when a patient comes with the right trapezius pain, for example, we are always like, you know, the common thing is they're probably taking even more medication for that pain. And, you know, we can look at, maybe it's the liver that's the problem. So because of the right diaphragm not moving correctly, and always sending this aggressive signal to the innervation of C3, C4, and C5, which we're going to look at pretty soon with embryology and more anatomy.
Okay, that's awesome. Let's see what we've got here. You know, we've got some anatomy aspects to let them see what we're talking about. We've got the pleura. Here we've got the endothoracic fascia, you know, that it's really close to the pleura and connects with the diaphragm and really covers up all the lungs, you know. And here we've got the transversalis fascia. This is something that you know a lot of knowledge, you know, and you're going to talk later on, Tom. And here we've got the esophagus here. I think that this is very important to let the people know that with all the herniated esophagus stuff, you know, and all this pathology, you've got lots of things to do. You only, you know, with what doctors do, they send you some pills, you know, and we've got lot of scientific works that tells us, you know, there are some osteopathic clinical trials that have seen the good evolution of patients doing some visceral treatment, and even though looking to what the diaphragm can do over there.
Definitely. I think that once we treat the diaphragm, we're solving so many problems and all the connections related. So it's amazing. I think I would treat every patient almost for the diaphragm just in case.
Yeah, me too. You know, I do the same as you. Here's another one. You've got here another connections. We know it's the endothoracic fascia. Here you've got the diaphragm. This is a very important aspect. You know, we've got here the transversalis fascia that is going to be very important with the evolution of the diaphragm. Here we've got with the irregular, you know, here you've got the irregular anatomy of the esophagus, you know, to make all the acid, you know, make it difficult to go into the esophagus, you know. And then this is you know, I think it's some anatomy aspects that are very important. Okay, we'll see in another slide what we've got here. This is something that we talked about and this is something really important, you know. This is recent, you know. This is something that we've seen in 2020. You know, they got the evidence that the esophagus is connected with the phrenic nerve, with the celiac plexus, and with the vagus nerve. You know, that is my opinion, you know. Here you've got, you know, that the phrenic nerve should try and stimulate the muscle to lower the tension. You know, that is my opinion, you know. And that is why people, when they are stressed, they are very active, they don't sleep, all that stuff that we constantly hear in clinics, you know, that is why they get the reflux. You know, that is my opinion. You know, I don't know what you think about. And that's why when they are calm, when they are, you know, they are relaxed, the vagus really has the tension and the status to contract and lower that sphincter, you know, and let the stomach do what they have to do.
Definitely. There's some crosstalk, very important crosstalk, because in case of, for example, vomiting, the vagus actually inhibits the phrenic nerve so that you can vomit and so on. And when and swallowing is the same case. So if it wasn't for this case, we would just regurgitate the food all the time, and we would, probably die really quickly. So it's something that's very important. And as you said, with resting, it's really interesting because there have been some studies about how in the supine position, the proper phrenic function is important in rapid eye movement. So basically, if there is no phrenic function, the person doesn't go into deep sleep. And this is really dangerous for, in the long run, for cardiovascular diseases and just in general regeneration of the body. So we only get about 2 hours to regenerate at night out of the 8 hours we sleep, which is very little. And imagine if the phrenic nerves are not working, we're not getting this rapid eye movement, and we're not really going into deep sleep. So this is really interesting. Also, with vigorous activity, we need a lot of phrenic work. So the phrenic nerve is so important that, as the Greeks said, the name comes from the brain, so it controls everything.
Yeah, that's it. We are a bit phrenic freaks,
Exactly.
Okay. So here we got something that you're going to talk about, and let me know when you want to go to another slide, Tom.
Perfect. Okay, so as you see here, we have in the middle in the aorta, and exactly, and just on one side of the other, there's the two cruces. The esophagus cruce with the right part and the left cruce, which actually is innervated only by the left phrenic nerve. The right is innervated by both the left and the right. So we have to analyze both sides of the neck pain when we have some gastro-reflux problems. And as you see that this part is very important because this is the part that is innervated by the vagus nerve, and it does this. It has a different embryological origin that we'll talk about it soon, so that you understand how the diaphragm forms. Because like Aristotle said, that when you see something grow, you understand it better. So, so if you plant a seed and you see it grow, you will understand the plant later on. But as you see that there's a lot of connections to this part. The vagus goes and it controls the sphincter, which is really important. If the sphincter is not working correctly, if it's a bit weak, then there's this hiatal hernia and there's this acid reflux, and we're gonna have tons of problems with that, including even what a lot of people don't know, cavities. Okay, so in your teeth, you have teeth problem because of the acidity in your mouth, which has to be alkaline.
And some speaking problems,
Exactly. We'll have vocal cord problems, and remember that since it's related with the vagus nerve, we can have all types of different reactions with this nerve. As you see here, there's this ligament of Treitz, which is the suspensory duodenal ligament, which is really interesting. And this is actually like, doctors actually say this is the center of the digestive system because it separates the upper and the lower digestive system. And embryology is really important because it does a rotation of this intestines. If this rotation doesn't happen, we're going to have a lot of problems, health problems. But as you see also with this part of the diaphragm, it will actually, this ligament will actually work as a valve. So it will help with the transformation of this. And in this like duodenal flexure, there's the mesentery root of mesentery that goes all the way to the ileocecal valve. So we can have, just from this little part of the esophageal sphincter, we have all kinds of digestive problems that we always have to analyze in the clinic, which is really, really great. You can go to the next slide, Raul. Thanks.
Okay.
Okay.
Really amazing picture, Tom.
Yeah, I love this because we know we have a lot of problems with hiatal hernias, A lot of them are actually asymptomatic, so patients won't know until something really bad goes with it. They might get some acid reflux, or not, or sometimes you could get some really big problems. As we see, we have what happens is with the hiatal hernia is the esophageal sphincter is it becomes a little bit weak. And why does this happen? Well, a lot of times we could say because of the diaphragm.
Yeah. But I
So
think that you've got there some important aspect here with the abdominal pressure and the thoracic pressure. You know, that's why if the diaphragm doesn't work, you know, you're going to have for sure some problems over here.
Exactly, Raul. I don't know about you, but just working the diaphragm makes wonders in acid reflux, which is, getting that diaphragm controlled, getting it pumping again, and that even can reduce the incidence of the hiatal hernia. As we see, we have three types. One is the sliding, which actually the part of the stomach goes through the esophageal sphincter. We have the rolling, which the stomach actually goes through another part, and we can have mixed, which are the worst ones, which
Yeah.
we can only pray to God for or get probably surgery in this case. Raul, which kind of hiatal hernia do you most often have success with when you treat?
You know, I've got more success with these ones, but a bit difficult sometimes, you know. This one I really think the same as you. This is one is so close to some surgery, you know. It's a bit difficult to solve this one. Okay.
Correct.
Because this is the evolution of these two lesions, you know, when they continue and when you don't do nothing here, you've got this problem. Okay, that's great, Tom.
Great.
Okay.
So here is the left part of the diaphragm. As we see, there are a lot of connections with the diaphragm. So let's go with the important but less important, and then go to the liver later on, which is amazing with how it influences the diaphragm. As we see, we have this little organ called the spleen here. Now, the spleen is also underlooked organ, but I love the spleen because it's so important for the immune system, especially with filtering blood, and it's like a cemetery for old blood cells. So we need this to function well. You know, in cases of car accidents, for example, a lot of people, when they have their spleen removed, later on, they're constantly sick. Now, when we have an enlarged spleen because of an infection or something, that also can compress in the stomach and will create problems like lack of appetite. But as you see, the thing that's important is that it influences the movement of the diaphragm. And there is a common medical sign that's called the Kerr sign, where you have left trapezius pain in case of splenomegaly, which is the enlargement of the spleen. Also, as you see here on the corner, we have the connection with the phrenocholic ligament, which is also important for digestion, expulsion of feces. And this is the area of fermentation. So if you're around somebody and when they fart, you have to walk out of the room, you got to treat that side of the diaphragm, because when it smells really bad, that means that fermentation is not going well there, and maybe there will be some spleen enlargement, maybe some pancreas problems. You see the tail of the pancreas, or simply that diaphragm is not working.
Okay. Okay, that's great, Tom. Really awesome connections here. Okay, we see.
Okay, and liver, Raul, you know, in clinic, we treat the liver almost like every patient or every other patient. It's such an important organ, which has 502 vital functions. 502 is amazing. It's like, those are just the vital functions, you know? So we can get an enlargement of the liver, especially in cases of menstrual problems in women or menopause. You will always have an enlargement menopause, because let's just put it that way. When the hormones go into war, that liver is going to suffer. So that liver is really, really important with the diaphragm movement. And for example, in dissections of the liver and the diaphragm, you really need a sharp tool to separate them, because there's a capsule, a glycine capsule, which actually the innervation is the same. It comes from the phrenic nerve, C3, C4, C5. According to some authors, C1 to C7. As you know, Raul, there's been some changes in the theories and so on. But basically, you will see a lot of problems, especially on the right side of the diaphragm, when there's a liver problem. So that will also affect the right shoulder. And as we talked about before, the trigeminal system in the right side, maybe some eye pain, and different types of causes. Remember, a liver is a very heavy organ, and it has a lot of influence and on everything in the body.
That's it.
Yeah. Okay, and this is kidneys. If you see the kidneys, kidneys and the suprarenal glands, and you know how we get stressed out. Well, when we get stressed out, what happens? That diaphragm gets spasmed, yeah? And the suprarenal glands are really responsible for the production of different hormones, which will make you stressed, yeah, which will make you fight or run.
25% of the sexual hormones, okay, are there.
Exactly, in the suprarenal glands. So exactly, Raul, like you said, people that have fertility problems or impotence, we can also have to look at their stress levels and treat that diaphragm, because if you see there that that fascia that covers the liver and the suprarenal and just goes directly up into the diaphragm, and it kind of attaches, it just clings on the diaphragm. So the movement of the diaphragm will affect renal function, and especially suprarenal function, because they're so close to the diaphragm. And one thing we see here is this angle is the pleura. So there will also be, of course, in the diaphragm, as you see this angle, we could have some dysfunctions. And also in cases of cancer and different hiatal problems, we'll have some interconnection and maybe metastasis in this area.
Even though there's something that some osteopaths have, done some scientific articles, they've seen then that when you've got a low back pain, it's very common to see that the kidneys move less. When you breathe in and when you breathe out, the kidney, I think it moves, it moves close to 1 centimeter, And they've seen that when you've got low back pain, that movement it's fewer, it's less, it goes worse. The kidney moves less, So that is something that we could criticize, and we could relate it with pain. When you've got pain, your diaphragm gets blocked, and in inspiration, blockage, here this way. So this is something that I tell my students, and I talk to physiotherapists, and we've talked about the same relationship, and what we've seen in a patient is that something that you have to do with low back pain is review your diaphragm, the movement of your diaphragm.
Exactly, Raul. Like you said, in the inspiration, the diaphragm moves, lowers, right? So it would compress all those visceral organs. And that would also give a sign to the back saying, there's a problem, there's a problem, there's a problem. And we'll have muscle spasms and different blockages there and inflammation going on. So it's very important to breathe in and breathe out and exhale, which is something when we're stressed, we don't do. Because as you know, Raul, when we inhale, we are actually activating the sympathetic system, and when we exhale, we're activating the parasympathetic system, the system of relaxation, of digestion, and of sleep. So what we need to really do is exhale, and something when we were people that are really stressed out or have anxiety, they never exhale, which is contributing to this deadly cycle of pain and of suffering.
Yeah, that's it. That's great, Tom. Okay, so here we got some very important embryology relationships.
Mm-hmm. Yes, Raul. Like I said with Aristotle, I love embryology. Before I was saying, why do we study embryology? But to really understand anatomy, you have to study embryology and how to see how the system works. And we are osteopaths, so we are always looking for the origin of the problem. And the anatomy is so important in all cases. So once you get to a certain level, you really need to get into the embryology to understand everything. So we can see that there's the interesting here is the diaphragm. Why is it related with the phrenic nerve, which comes out of C3, C4, C5 in the neck? People are like, wow. When I explain to every patient this, that their neck pain is influenced by the movement of the diaphragm, they don't understand. But I kind of explain to them that during embryology, as we see in the first part of this slide, we have the diaphragm that actually starts to develop inside of the neck, really close to that C3, C4, C5 level. And so it takes the somites, which are in the back, and it starts to make connections with that area, and that forms the phrenic nerve, basically, to say it really simply. Now, what happens in the second picture is the somites actually start to grow very quickly. So the fetus starts to kind of become a C and encircle. And the diaphragm doesn't actually descend per se. It just, because it kind of, the other part, the back part, the somite grows so quickly that this part just actually starts to lower naturally. We could say it's an optical illusion, but it eventually gets into the thoracolumbar region in the L1 region, D12 L1 region. And, but the phrenic nerve stays. It just kind of travels along with the diaphragm towards the lower part. And another really interesting part is that the C3, C4, C5 region is really important in obviously neck and shoulder action. So the somites, the diaphragm develops from exactly the same somites that some of the neck muscles and the shoulder muscles. So that's why we will have, when we have diaphragm problems, we will have upper limb problems too, which is amazing. And you will see this because if you inhale, it's a lot easier to raise your arms when you inhale than if you don't, for example. And this is kind of this coordination. So in the clinic, we will see almost, I would say almost all patients, I'll be lying to you, but many patients that will have a lot of shoulder problems, and they will have at the same side really bad hemidiaphragm movements.
Mm-hmm. Great, Tom. Okay.
And just to kind of to show you how it goes on the transverse cuts, how the embryology happens, because the diaphragm actually forms from four parts. Three that kind of continue into adult life, but that's why there is such different innervation between the diaphragm, different functions, because really the diaphragm is like a few things that come together and they join, and that's because of this. So we see here in picture A that we have the first part that it develops is actually the septum transversum. The septum transversum is present in all mammals, in reptiles, and in birds, not in fish or amphibians, but it does start to develop in reptiles and birds, which is interesting. But the septum transversum is what later forms into the central tendon, okay? And the central tendon, as Raul, you said before, with the pericardium, with the heart pump, it's going to be very important for blood circulation function. And this central tendon, becomes a tendinous part. Septum transversum comes from the mesoderm, so it develops from the same types of material as muscle and ligaments. And then we have the pleural peritoneal folds, which are on the sides. And these pleural peritoneal folds kind of disappear through age, through time. But they are actually the most important for the part for integration of the diaphragm. So they connect the parts of the diaphragm. They actually take the phrenic nerve and they bring it to the septum transversum. We really need good function of these peritoneal folds in embryology. And if they do not close, as you see, they close. If they do not close, we have congenital herniated hiatal hernias, sorry. And the third part that's at the beginning is the crus part, the middle part, which we talked about before, that there's a vagus innervation there too, and it comes from the dorsal mesentery of the esophagus. So it has, it's a muscular organ, but it has a kind of digestive part. So it's really important for the digestion of everything. And for at least, finally, there is the muscular ingrowth. And the muscular ingrowth comes from the somites, also C3, C4, C5. And what happens is that starts as very small, thin fiber, and then it keeps expanding until it mostly covers most of the diaphragm, taking over the pleural peritoneal membrane and just keeping the phrenic, central tendon there. Interestingly, the septum transversum also develops into the glycine capsule. That's why the capsule that covers the liver comes from the C3, C4, C5. That's why when you have liver problems, you will have also neck pain. So that's the embryologic region. Now, one interesting thing to say, the diaphragm for the muscular part of the diaphragm, the reason we have different innervation, we have like sensitive innervation of the lower costals, is because of this embryological development. And another thing interesting to say is only mammals have this muscular part. And this is why they say it's very important for various functions like homeostasis of temperature. So, you know, we are warm-blooded. And that another thing that could relate with our circulation. So that's the embryology, 4 different parts, and then later on everything comes together, which is still not explained very well why it comes together, and there are many different theories, but maybe you guys can figure it out in the future. And last but not least, this is the view of how the lungs develop, because, you know, obviously the lungs are very important for human functions. The most important is to breathe, and if everything else is secondary. And you see in the first part, you see the central or the septum transversum. As you see, it stays with the just below the pericardium, and that starts to outgrow with the pleural peritoneal folds once the lungs start to develop. So that will help to divide that embryologic part, the upper part from the bottom part, or the fluids, so they don't interfere into each other's work. And in the last picture, we see there's the muscular ingrowth, and you see the pleural peritoneal folds become very small. Now, there's not much, there's some theories of what happens with these pleural peritoneal folds, but it's not very well known what happens in adults yet. So also another thing for this.
Very interesting, Tom. So you've just explained some very important task, you know, that that relates with something really common that we've got in you know, we've got with our patients complain, you know, when a patient tells us, you know, I've got a neck pain, excuse me, that comes this way, you know, I forget about the neck and I begin to think about the phrenic nerve, about the diaphragm, about the mediastinum, you know, I forget. And this is very, very common when you've got these patients in your clinic. And it's something that I find that physiotherapists and students don't really connect and, make a twist, make your mind twist and forget about the patient's complaint, and began to think about function, about neurophysiology. You got here something very important that is something that connects everything. You've got some books, that Steckel wrote, that even though the phrenic nerve connects cervical regions, the C3, C4, C5 region, with the genital plexus, with the genital organs. And, here you've got some patients complain with some ovary problems and, some neck, some cervical pain. This is something that happens to me, Raul, and I don't understand. I've frequently have some cervical pain, and, I really think it's related with my hormone system, and I say, that's the phrenic nerve. We're going to start working it. And you're going to find out how you're going to have your neck pain, maybe not solved completely, but, relaxed. You've got your neck pain is going to lower down really in a high amount. Here you've got all the muscle fibers over here, the type 1, type 2. We're not going to talking about this because it's going to be really large. The diaphragm has 4 kind of fibers here: type 1, type 2, type 3, and type 4, with some subdivisions. And all of them are going to talk with the system, are going to make some afferent to the C4, C5 region you've just talked about. They're going to send some information of how the diaphragm is moving, is contracting, is lowering it down, it's moving the lungs and the pleura, and they are constantly going to give this information when they breathe in, when they breathe out, and when they relax in those few seconds that the diaphragm relax. So this is very important for us to know that here the pericardium is going to send some afferent information through these afferent fibers here. Some articles tells us that the phrenic nerve has half afferent and half efferent fibers. This is something that really made me I thought that the phrenic nerve was only efferent. It only pumps the diaphragm down, it lowers the diaphragm fibers, and something that really got me really confused and made me, start to look in PubMed and look some articles. Was this new stuff that I read, And this is very important because this is the way that the diaphragm, what you just said, the Gleason capsule, here, the kidney here and the, and the suprarenal gland, are really close with these afferent fibers, and they get this C4 pain. This is really common. You find out that you've got one C4 joint fix, you make some test and you say C4, some EOM student told me that there are some afferent relationship with the diaphragm. Let's do some diaphragm techniques. We pump the diaphragm, we lower the diaphragm, we breathe in, breathe out, we do some mediastinum techniques, and the C4 joint disappears, this function disappears, Tom.
It's amazing, Raul. It's amazing what we can really do and accomplish in osteopathy. And as you said, a lot of times this is when the problem for students happens, is they don't connect this, and they start to treat the symptoms. They start to treat just the neck, you know, but they forget about the origin of the problem. And if we don't get to the origin of the problem, we're never going to solve anything. We need to really be like detectives. So I love osteopathy because it's being a detective.
That's it, Tom. That's it. Okay, some very interesting aspect you're going to talk about, Tom.
Great. Well, as you know, the diaphragm is involved in inhalation, right? So it relaxes and it exhales through abdominal muscles and through other muscles, accessory muscles. But you know, when we do proper diaphragmatic breathing, we don't really activate so much the upper part, which is when we are, for example, in stress. We start to breathe with our shoulders and not so much with our belly, with our diaphragm. But obviously, there is a connection in inhalation between the diaphragm and the thoracic outlet syndrome, and also the movement, as I said before, because of embryology, because of movement of the shoulder. So the shoulder and the diaphragm, if you have somebody with a shoulder pain, 100% you have to look at the diaphragm, see what's going on there. And now there's an interesting little muscle called the subclavius muscle. It's a small muscle. I always say the small muscles, they're like small dogs. They give you the most problems, like the little chihuahua that doesn't stop to bark. Yeah, the big one is nice and noble, and the little one is the problem maker. Yeah, you know that from your neighborhood when you were a child. So with the subclavius muscle, what it does is it stabilizes the clavicle. It's also important in fractures because it protects the thoracic outlet area. So in a lot of babies, they have these fractures just through birth, and later on, you know, that doesn't get diagnosed, and later on they'll have tension in this area. And next thing you know, that the same problem, let's say the right clavicle is broken, they'll start to develop hormonal problems. Why? Because the liver's not working properly, because the diaphragm is not working properly. So here's the detective work. Now, the little subclavius muscle, what it also does is it raises the first rib by bringing the clavicle in anterior rotation. And when it does this, what it does is that helps with the inhalation. But if it stays there, if it gets blocked, then, you know, we're going to get this thoracic outlet syndrome because that area is going to be compressed. Simple as that. And the interesting thing about the subclavius muscle is it's innervated by the accessory phrenic nerve in 68% of patients. According to some studies, 21%, but up to 68% of the most recent studies have the accessory phrenic nerve, which connects with the phrenic nerve. So the phrenic nerve not only is responsible for breathing and from all these other functions, but also is responsible for raising the first rib and communicating with the diaphragm, that this all goes in tandem and not out of place. So always, a lot of times we will see in the clinic, we'll see the thoracic outlet syndrome, first raised rib, and, for example, spasm of inhalation in the same side of the diaphragm. Let's say you have a liver problem. Well, you know, because you haven't slept, you ate a lot of sugar, and you're really stressed out. And on top of that, you have hormonal problems. Well, you're going to have that the right diaphragm a little bit worse than the left one. That's going to be an inhalation. So this area will adapt to it too. So we'd also have to treat the liver and treat that first rib at the same time.
Okay, really, you find this stuff, you're going to manipulate the first rib. You can't do it because you find a lot of tension. You solve all the diaphragm problems, the liver problems. You do some pump diaphragm, some pump liver techniques, and later on you try and manipulate the first rib, and you only get it, you put the correct position, and you do a a simple, thrust, and you get it manipulated. That's some very important aspect, Tom. Okay, you've got it here. Here's the connection.
Mm-hmm. Yeah, as we see that, the accessory phrenic nerve in most cases, it has its origin in a scapular nerve or subclavius nerve that forms a subclavius nerve, which just goes to this little muscle. And as you see from there, it actually goes around the subclavian vein. So it's interesting because if you have, for example, compression of this thoracic outlet syndrome, you will also have problems with the phrenic nerve and even more problems in that right diaphragm. So, and also if you see like a lot of bad blood flow, that's going to happen. And when there's, the blood doesn't flow, pain starts to happen.
The patient doesn't flow.
Yeah, exactly.
Okay, that's really a really strong connection with C4, C5 we've got here. You can forget about it. Okay, this is really some, it's a it's a picture that I got, that really connects and really matches with what we talked about, Tom. We've talked about some cervical pain, some neck pain, all the anterior, that this is something that we forget here. When the patient starts to complain about the anterior trapezius pain, they constantly say this, I've got some pain over here, forget about it. Let's talk about the diaphragm. Let's see how you inhale, how you exhale. What's your postural, image when you are standing, and we see lots of referred pain coming from the diaphragm. And this is something that we can't forget, you've got here what you've talked about the liver and the gallbladder. This is something that you find with the medical articles when they do a surgery in the gallbladder and they get it out. This is something really, really common. 24 hours after the surgery, there's a complaint of the patient of some right pain shoulder, that is so often, even though I don't know how to say hysterectomy. Did I say it correctly?
Sorry, well?
Hysterectomy.
Yeah, hysterectomy. Yeah.
Thought I was saying something different. Even though when there's some women problem when they've got an hysterectomy surgery, they also talk about right arm complaint. So this is something that really matches with what Carl Azteco wrote down, that talked about the phrenic nerve relationship with the myoepithelial cells, that all the cells, the muscular cells that covers up the glands of these organs, the genital organs, have some phrenic connections, phrenic connections, This is something really useful that we have to have, because if the patient tells us that she's got some cervical region problems, I'm talking about the uterus and this stuff, but we've got something really common with the prostate, this is so close and it's the same referred pain. So when the patient finishes the surgery and she's complaining about some cervical pain complaints, I can't rotate my head over here, I can't side bend, I have some cervical pain that I didn't have, before the surgery, you've got to talk, you have to think about the phrenic afferent fibers that are doing this particularly compensations on this particular pain that the patient has.
It's interesting what you said, Raul, because with the accessory information that we're sending, imagine we have an ovary problem that we're sending, we need to send this information for the diaphragm for protection. So that's also going to affect this diaphragmatic movement. And, as you know, like people that are in constant pain and chronic pain, the diaphragm doesn't move at all. It's so stressed. Perfect. They're always in protection, right? So we can look at it as also this psycho-emotional, the phrenic nerve being the psycho-emotional connection too. as you know, Raul, in the midbrain, it actually connects with the limbic system. So, you know, that's amazing how we can, with just the emotions, we can affect different parts of the diaphragm, and it's
That's great. That's
wonderful
great.
world.
Okay, here we've got how it does, you know, the afferent fibers of the diaphragm are going upwards, you know, they're doing some ascending projections and they get to the C4. Right now here we've got in the C4, it's called the dorsal nucleus of the phrenic nerve. You know that this is why we've constantly have these cervical complaints of our patients. This is the anatomy and physiology aspects of the phrenic nerve, and this is why C4 is getting activated. You know, this is why C4 gets in some dysfunction, and you've got, you know, we were going to repeat it, you can have some C4 joint dysfunction that comes from some diaphragm dysfunctions, you know, and you can try and forget about manipulating mid-cervical region, that it has lots of particularly difficulties and something that you have to, maybe they can have some degenerative, you know, aspects that you don't realize in the joints. And maybe you could try and think about what Tom and Raul told me. Let's see what happens with the diaphragm. We could try and do some diaphragm techniques and see what happens with this joint. This is the clinical, you know, some scientific knowledge that you can forget about, and you can say this isn't happening, you know. And all these ascending projections, you know, they get what you just said. They get to the cingulate gyrus, the anterior cingulate gyrus, even though they were related with the cerebellum. You know, we've got some very strong scientific articles that has the conclusion, you know, you've got this for sure. Diaphragm is related with postural improvement. Diaphragm is related with herniate disc complaints. You know, even the more related scientific knowledge we've got is with the lumbar region. So here we've got some strong connections, even though, Tom, here we've got some low connections with the nucleus of the solitary tract that is receiving all the afferent of the visceral regions. It's getting all this information all through the vagus nerve. Even though it's getting a very strong connection, and here we've got it with the reticular formation or the lucus ceruleus. Don't know how you say that. I think it's that way. You know, that is going to get some really strong connection with the, how you say, how active and the attention that the patient has. The, you know, how, don't know how to say that. Let's see if I can find the word. Okay, well, I think about it later.
Okay.
How the attention level of the patient is.
Attention span.
Yeah, that's it. Okay, so that is how we can manage through some breathing, you know, deep breathing techniques that we've talked a lot about them. You know, that's why they get a efferent connection, and how the patient has this soluta, you know, when you breathe in and you breathe out, you get this afferent from the phrenic nerve, and even though from the vagus nerve, it does disconnect, it lowers the intensity of the activation that the reticular formation gives to the patient, how alerted is the patient.
Mm-hmm. Fascinating, Raul.
And even though it gets a connection through to the hypothalamus, to the paraventricular part of the hypothalamus, you know, that's related with how you dream.
Excellent. Excellent. Yeah, so that's the REM cycles, and if you in probably there would be some hormonal function too, right? Because of the hypothalamus. So this is amazing how everything's connected neurologically. We can, and the beautiful thing about this is when maybe in 10 years we'll do a chat like this, and we're gonna have so much information, so much new information, because there's so much being discovered. And that phrenic nerve, I think, is just something that's gonna be a top hit in the future.
Oh, we do 10 years.
Exactly.
Okay, so here we've got some connections that are going to relate with the vascular task you've talked in a few slides, you know. Here we've got the diaphragm with this circular anatomy here, and how it's so close and so related with the pericardium, you know. Here's the heart in, and how it's related with the dorsal upper region. Here we got some very strong connections, and something that you can it's all mixed up, you know, the diaphragm and the mediastinum. You know, that's something that I think I do practically always with my patients, review diaphragm and the mediastinum.
Mm-hmm. Yeah, as important the mediastinum is is that's where all the orthosympathetic system sits. So we can, and actually it's very relaxing to have your sternum worked on, right?
That's it. Okay, so here's what we got here. Here's the simple anatomy. You know, you've got the right dome here that gets to the fourth rib, and the left dome here that gets, you know, to the level of the fifth rib. You know, here we've got the information that when you inhale, the central tenderness of the diaphragm is going to go down, is going to lower, and this lowering of the diaphragm, this inspiration movement that the diaphragm is going to do, is going to firstly lower the vertical region of the thorax, the upper thorax. It's going to lower down. It's going to finish this movement through the lengthening of the mediastinum, and when it gets so close to the visceral of the abdominal wall, you know, it goes down. The vertical region is going to go down. We're going to get the tension of the pleura, the mediastinum region, the mediastinum fascia, the endothoracic fascia, and we're going to finish when we get to the pressure that the visceral organs of the abdominal wall gives us. And when it does so, Tom, it goes to the thorax is going to expand, getting some lateral movement of the lower ribs. It's going to move down, and, you know, getting this movement that we check when we are testing the diaphragm, you know.
Perfect. You know, I like to explain it as opening up an umbrella when the central tendon opens.
Great. I get it. I'm going to get that task. You know, I like that one. Okay. You know, and there's going to be another movement, and a posterior and an anterior movement that the external fibers of the diaphragm gives us. You know, you're going to have this breathing movement of the thoracic ribs, the upper ribs, and the lower ribs that are going to give us this movement that we have to check when we are testing the diaphragm. Okay, so here we've got some really, really amazing connection. And this is what we got here in our abdominal wall. Here we got why when we do some diaphragm techniques, we're not looking only about breathing improvement. You know, we're looking out to some vascular aspects, you know, that we can see here in this image. You know, here we've got the diaphragm, we've got the aquatate medial ligament that gets the aorta, you know, it covers the aorta and the thoracic duct. Here we've got not only this one, we've got some coronary ligaments of the liver. That's why the liver connects to the diaphragm, the coronary ligaments and the triangular ligaments over here. Getting they all some you know, the cover up of the peritoneum. You know, here you've got some branches that the aorta gives to the small intestine, you know, even though to the genital organs here. That's why this is so important for the evolution of some osteopathic visceral problems of a patient.
It's really, really important, the arterial system, as we know. If blood gets there, their health will get there too. So the more blood we have in different areas, the better things will start to work. And if you see their arterial system, you can do, if you take all of the arteries and put them together, we do twice, just for one person, we do twice go around the world, which is amazing how much blood there actually is in a human body, how much connections there is. So we got to keep those rivers flowing. If that river, if something is blocked, then that river is not going to have the health benefits we're going to do. And as you know, Raul, there's a lot of studies being done right now in working the arterial system and how effective working the arterial system is, which is really when I saw patients, when I started to work the arteries, when I saw patients improve greatly, like chronic patients improve right away. So, but obviously the diaphragm will influence all of these connections, and if there's some adhesions and some tensions there because of inflammation, local inflammation, that blood is not going to flow very well.
Yeah, you know, when you're treating the artery system, you're getting in the autonomic nervous system. You know, that's so important for physiotherapists and osteopaths. You know, this is something that I really go along with my patients. You know, here's some important tasks. You know, we talked about the lymph nodes here and all the thoracic duct and all the inferior vena cava. You know, pumping, you know, when you inhale, you know, this sphincter, you know, it gets lower, you know, it lowers the diameter, you know, and when you exhale, it gets it gets bigger, you know. That is why this inspiration, expiration, inhaling, exhaling pumps all this and improves all this venous system. And even though the lymphatic system here, we've got here all the anterior lymphatic nodes here, when you inhale and you exhale, you have this branch that connects with the thoracic duct, you know, the thoracic part of this duct, you know. Okay, so we've got this.
One thing I want to say about this is, like, in case of varicose veins, you know, for a lot of times you'll see a patient with right leg, a lot of varicose veins, left leg is okay. So what's going on in the right side? Well, maybe that diaphragm is not pumping very well in the right side. Maybe that vena cava is compressed, because compared to the arteries don't have much compression, because, you know, you need those to be open to stay alive the whole time. But veins, yeah, they do compress and they open, and they're very well influenced with inflammation. So if there's inflammation, there will be nerve pain. There will also be one of the things you can always look at in your patients is varicose veins, and see, like, the right side varicose veins, pump that diaphragm.
Okay, and here we've got the cisterna chili, you talked, Tom, that it receives all the abdominal lymphatic, flow, and it gets it upwards to the to the heart, and that's why it gets all this stuff. It gets pumped. You can forget and you can separate lymphatic system and venous system. You can you've got it all mixed up, and all intertwined. Get them into they work together. Okay.
Yeah.
So Tom, we've got it done. I think this is the last slide. So we've got, I think we've given our students or future students and some of physiotherapists, our colleagues, some really interesting information that they could use for the patient's treatment and to do a good diagnosis of the patients,
True that. Yeah, Raul, like diaphragm, if you breathe, I mean, we can talk about nutrition, we can talk about doing anything, but if you can't breathe and you can't breathe correctly, nothing works. As we know, when the phrenic nerve is problematic, or even if there's a dissection in the C2 level, the person dies, because we need that diaphragm to move. And it's so important in everything. It's the center, it's the soul, it's connected with just about everything, and it's the motor. And we have influence of this, and we as therapists, as osteopaths, we can really influence the movement of everything and solve a lot of problems.
Okay, that's it. So we're going to say bye-bye to everyone. We'll see you soon. Hope to see you soon. And that's it. We're Phrenic Freaks. Hope you continue reading some stuff, in PubMed and Science Direct, and all the books, Carla Steco, and here's the information that we can give you, and hope you received it and you get it. Okay.
Great. Thank you, Raul.
Everyone.
Thank you.
Bye,
everybody.
my dear Tom. See you soon. Hope to see you soon.
Bye.
Bye.